But a lot of doctors say that ECG does not tell the whole story. That men and women don't have similar heart attack symptoms. So, what is it that you have observed?
There was a time when alcohol was pitched as the cure. We cannot recommend alcohol in any particular dose. Look at your diet, what you eat in terms of balanced diet. If someone has chest pain at home, go to your nearest emergency or hospital.
Hello, everyone, and welcome to another episode of Healthy and Hearty. Today, we are talking about the heart. How to keep it healthy, what warning signs we should never ignore, and what really puts our heart at risk. Joining us is Senior Interventional and Structural Cardiologist Dr. Gautam Nayak, who will answer your most asked questions. Welcome to Healthy and Hearty, Dr. Nayak.
Thank you very much.
Today, I'm sure there's so much that we'll discuss that's so important. And, before we dive into a deeper topic, I want to understand from you, in your OPD, what are the kind of heart cases that you see these days?
First of all, thanks for having me on this podcast, and good morning to my audience, or good evening as they might want to have. So yes, that's a very important question which the viewers would like to know. So in terms of heart disease, there's lots going on within the heart. So you've got the preventive heart part of it, whereby you have to take in terms of control of your cholesterol. Someone comes to you with a high blood pressure,
Right.
so on and so forth. Then there is something which is called a secondary prevention, which means that the disease has set in. There were risk factors which were not taken care of, and the patient is presenting to you with heart disease, and now you have to tackle it, be it coronary disease, be it valve disease, be it heart failure, so on and so forth. Then there is something called as tertiary prevention, which means the heart disease has set in, it has caused some damage, and now you're trying to revive whatever you can whilst you're, so that's a very late stage. And there is something which is primordial prevention. So when we talk about primordial prevention, so things which are under our control are when you start from 18 years of age or even before that. So that is when you can prevent risk factors from coming in, which will halt the progression of at least coronary heart disease, which is the preventable type of heart disease. Correct. Which normally in a severe form you can call as heart attacks, strokes and the like.
So I want to understand, since you spoke about patients as young as 18, abroad, since you've worked in UK, so I've heard that heart tests, heart screening begins as early as 18 outside. That's what they're pushing for. But that's not the case in India. So what would you like to say?
Yes, well, yes and no. People are becoming more aware. So, I mean, sure, people would want to know what the regular risk factors are, what can be done. So there's obviously modifiable and non-modifiable risk factors. Age and gender are obviously non-modifiable. As we grow old,
Right.
the biggest cardiovascular risk factor is age. We can't change it. What we can change is make sure that we develop healthy habits. What do you mean by healthy habits? The next question might be. So A is, look at your diet, what you eat in terms of balanced diet. You need to have a decent intake of proteins, cut out the saturated fats. Not all fats are bad. You need to pick and choose. Obviously now there is nutritional value available across the board on all our food products. So diet is the first thing. Get a healthy, comprehensive health checkup starting at 18 or 20 years of age. That will give you an idea as to what your current health status is and what the trajectory is, and how much of a risk you are of having heart disease maybe 10, 20, 30 years down the line. So
since there are so many tests, can you point out a few that are important at that stage?
Yes. So once you turn about 18-20, the first tests that you need to do is a cholesterol level, a lipid profile, which should include the complete profile, which will include total cholesterol, LDL cholesterol, HDL cholesterol, VLDLs. What is recommended is once in your lifetime you must measure, whenever you're doing the test, do a lipoprotein A, because we as South Asians have a very high predilection of this. Although there are no specific targets, it gives you a risk profiling. And then in terms of what you should be doing, a treadmill test and an echocardiogram. These are the basic health tests which a treadmill stress test will probably screen you in saying what is your cardiopulmonary reserve, how fit are you basically, and whether your heart can take the load. The echocardiography will tell you, and it's widely available these days. Health checks are being pushed both in the corporate sector and people running diagnostic centers, and so they are percolating within the system. So there's no excuse saying, well, we don't have access. There's very, very few places left where easy access to at least basic tests is not available. So coming back to the question, lipid profile, 3-month sugar levels, HbA1c, glycosylated hemoglobin. Check your blood pressure with your physician or cardiologist. Then go ahead and do an echocardiogram, which will tell you the structure and function of your heart. And then go and do a treadmill test that will tell you both your cardiopulmonary reserve, tell you whether there are any rhythm disturbances, and most importantly, tell you how fit you are heart-wise.
A lot of times when someone's experiencing chest pain, for example, they go to the emergency and the classic test that is done is ECG.
Yes.
But a lot of doctors say that ECG does not tell the whole story.
Yes.
And a lot of markers can be missed. So please, would you like to elaborate?
Yes, that is absolutely correct. ECG does not tell us the full picture. An abnormal ECG will tell you that someone is suffering from a heart attack or a very high risk of a heart attack. But a normal ECG does not rule it out, especially in the very early phases. I recently had about a month back a 28-year-old corporate worker had some chest pain brought in by his colleagues from the office. No classical ECG changes, but he had chest pain of about an hour's duration. We wheeled him into the cath lab, and one of the vessels on angiography was completely blocked. So this is not something which is science fiction anymore. We do get young patients in real life who are at risk because of various risk factors. To blame it on the genes is one thing, but to be proactive and take active measures is quite another. So this particular patient was a smoker. He was, because he was out of his place in the sense that he had come out of his state to work elsewhere.
Right.
He was not having, a regular tiffin kind of a service or a meal where he could rely on or eat. So he was procuring junk food from wherever he got. So there were risk factors which promoted this, and plaque rupture event is something which is, does not necessarily have to do when you are active. He was sitting in front of a computer doing precious little in terms of physical activity. So even a sedentary lifestyle, you need to be proactive, and this is investment for the next 10, 20, 30 years of your life when you're young.
Going back to the same question, if someone's, how exactly if we can, you can help us understand what are the classic symptoms and how do they really feel? Because every time someone has chest pain, it's like left or right. Right? Okay, it's not related to heart. Left, okay, it's heart. So how exactly, for a person, for our viewers, if you can explain?
So there are described typical chest pains. But the most important thing is there is no test which can categorically tell you that this is not heart-related chest pain. Only 2 tests, in my opinion, a CT coronary angiogram and an angiogram can be definitive. But to reach that point, if someone is developing chest pain, the most important thing is vigilance, because during a heart attack, time is muscle. So coming back to the question in hand, is that what is the typical sign of chest pain? It is usually pressure on the chest. There is something which is called as stable angina, which means you are walking or exercising and suddenly you feel a catch or a burning or a pressure, sometimes in your chest, sometimes in the neck, sometimes in the jaw. But as I said, in women, in diabetics, and even in men for that matter, these may not be classical symptoms. So the important thing is not to ignore, because heart related chest pain is the most serious type of chest pain. So sitting over it thinking, oh, it's just acidity, or I'm just getting old, I just had a catch, this is muscle, do not self-diagnose is the answer. You take medical opinion, involve your doctor, get a test, and ECG doesn't tell you the full story. Even in the emergency room, we take troponin, 0 1 and 6 hours, or 0, 2 and 6 hours, as the case might be in different settings. But this is how it progresses, because even at the onset of chest pain, someone doing a troponin, they must not be, so troponin is a marker of cardiac muscle damage, and it leaks out as a biomarker which can then be measured in the blood. But very early in this stage, chest pain often occurs before muscle injury starts setting in. So that's why we do serial markers, to be absolutely certain, and sending someone home, because once they are in the hospital, they are your responsibility. So you cannot be so coming back to the question in hand, there is no categorical type of chest pain. There is typical and atypical, but I would be very wary in labeling someone as atypical unless I do the relevant tests for this. So coming back to the question, if someone has chest pain at home, go to your nearest emergency or hospital. And yeah.
And you also briefly mentioned about women and people with diabetes.
Yes.
What are some atypical signs? Because we keep hearing that men and women don't have similar heart attack symptoms. So what is it that you have observed?
So even in women and diabetics, chest pain is the most common symptom. However, the percentage or proportion of patients presenting with atypical symptoms in these categories of patients is higher. Now, what is atypical, you might ask? So, atypical would mean some pain in the jaw on the left side predominantly. Many a times that can be an indicator of angina, or coronary blockage can lead to such things. Sometimes central pain radiating to the back or the left shoulder. That can also be perceived. Sometimes these patients have what is called as angina equivalent. They may not present at chest pain with chest pain at all. Rather, they might present with something like, oh, I'm tending to breathe heavily, or something like palpitations. I'm feeling hot, I'm not right. Sometimes they might have nausea, vomiting as symptoms, because there's a part of the heart which is very close relation with the abdomen and the vagal nerve. So and sometimes they might not just say, they might just say, well, I'm not feeling right. And that doesn't tell you much except for visit your doctor. So these are all the spectra of presentations that a patient with coronary heart disease might present.
Moving to stents. They are being talked about a lot. And in your opinion, I mean, a lot of patients and people tend to believe that a lot of unnecessary angioplasties are done. How would you like to address that?
Well, before casting aspersions on any cardiologist, the thing is that this data is evolving. And there was an era where we used to feel that, stents were not necessary, only plain old balloon angioplasty was enough. But then came data that these patients had re-blockages very early, so you had to get in stents. Then came the era where drugs were added to stents, and then the studies are ongoing. Now we are going back to an era where there's research ongoing with drug-coated balloons and whether leaving nothing behind. So that's the technical part of it. Coming to, are stents overused? Well, because there's a big gray area where we still do not have enough data. In ACS, what is ACS? Acute coronary syndromes, which are divided into ST elevation MIs, which is the most severe form of completely occluded blood vessel heart attack, versus the spectrum into very high risk acute coronary syndromes. Stents do benefit. They do save lives in selected patients. In stable coronary disease, we do not have ample evidence to suggest that they prolong survival. So there have been studies where optimal medical therapy, but you have to be very categorical about the stable coronary disease. Then you cannot, with a paintbrush fold every chest pain as one. So an acute situation, a heart attack situation, is very different from someone who's running a marathon and then developing some chest discomfort occasionally. So those two are, as I said, it's a spectrum. So just as your trouser sizes are not the same, you have to tailor your treatment to the patient. So every patient is different. the doctor or the cardiologist in question will evaluate all the evidence that is there in front of him, make a clinical decision, and then go ahead and decide whether or not this patient qualifies for a stent, or whether the stent will give him truly long lasting benefit. In stable disease, we try with medications often. Not all lesions that, if you see 3-vessel disease, there are 3 coronary vessels, you don't have to stent all of them. We then tend to follow them up very frequently in the clinic. So the answer is not at all. Not all blockages require stents. Bypass surgery is a very good option in selected diabetic patients. So there's a lot of options, and to give one categorical answer is not possible. It's a very nuanced process, and if you follow the book, and I would assume most cardiologists who are senior would do that, there's no reason to believe that stents are being overused.
Okay. And does getting a stent means that your heart is healthy now?
Yeah, that's a very common misconception. There is a psychological feeling. In fact, there was a sham control trial which I'll come to. Putting in a stent doesn't absolve you from whatever you need to do as a patient.
Right.
So it's very well to have a stent. If you do not take your medications regularly, after that you will come back with an even bigger heart attack, because the stent has now blocked. So doctors will prescribe you things like blood thinners.
Right.
There'll be statins, which are high intensity statins, especially if someone is having a heart attack, and so on and so forth. Drugs to control your blood pressure, drugs to control your heart rate, so that your heart, which is essentially a motor, will perform at its maximal fuel efficiency and go on for long. Stents do not mean that they last a long time. Some stents may last, the average across the world is about 6 to 7 years.
Okay.
Some stents might last even for 15 years, some do not last even for 6 months. But that depends again on patient factors. So whether the patient is a diabetic, whether they have a very high atherosclerotic risk, which means the chances of clotting in this patient are higher. So that is one category of patients. Then comes the technical factors, where you put in the stent, how long is the stent, how much vessel is diseased. So it's a combination of factors. It's just like someone saying, oh, give me a red color, yellow and green, mix it all up and tell me how much percentage is this, that and the other, which is, I mean, a ridiculous argument to make in itself, which is why, as I said, trust your doctor. He's doing the right thing for you. Putting in a stent doesn't always mean that you are safe. You still have to do the diligent work, still have to concentrate on your diet, still have to control your sugar, still have to do physical activity, still most importantly have to make sure that your medications are taken on time.
Right. And also workout,
Yeah.
something that's very important for heart health. So I want to understand, people go to gyms, they do marathons, they do all of that, and then we hear of these cases of sudden cardiac deaths. So is it important for someone to consult their doctor before starting a workout?
Very, very important question. And this is what we often tend to miss. A plaque rupture event which causes a heart attack, which is essentially buildup of cholesterol for a period of time, and suddenly it ruptures, giving rise to a complete blockage of a artery,
Right.
doesn't more often, in 85% of the patients, doesn't happen without a cause. There might have been risk factors which might have been ignored.
Right.
There might be chest discomfort which might be ignored as acidity. So especially getting into an exercise regimen, good to consult your doctor or cardiologist. Do these basic tests that we spoke about. It gives you a heart profile. It
Right.
tells you how your heart is functioning, if there's any pre-existing damage. So worldwide, there's a condition, a structural heart condition called as hypertrophic cardiomyopathy, obstructive cardiomyopathy, which is the cause of sudden cardiac death, especially in athletes who
Right.
have been, conditioned well. So, but they never did their echocardiogram. They never knew that, this thing can cause
Yeah.
arrhythmias and sudden
That they were
cardiac
at
death. Yes.
risk.
So,
Yeah.
coming back to this, do your healthy heart profile at 18 years of age. get your doctor to embark upon. Even patients who want to, I recently had a patient who wanted to climb the Himalayas and make sure people are interested in mountain trekking. By all means, yes. I'm proud to say that I had a patient who had 3 vessel disease, who was on medicines. I did not advocate stents for him, and he went up to Amarnath Yatra and came back with the prasad.
Oh,
Yes,
wow.
so and he was saying my wife was feeling breathless. She had the low oxygen tensions, but I did not. So it was glad and satisfying to hear that medications do the trick, provided you trust your doctor and do it diligently. So kudos to the patient,
Yeah.
not to me in this case.
Yeah, because we hear a lot of people while running these marathons, cyclothons, and all of that, and
Yes.
suddenly collapse. So
Yes.
it's worrying, and
There's a certain test I would like to pitch in through your medium, which is called the cardiopulmonary exercise test. It is available at most major corporate hospitals. So when you embark on something which is extreme, there's 2 things to ponder about. A is whether you get your cardiovascular health check. B is someone who's been a couch potato cannot go on and run a marathon the next day. You have to grade it. Your expectations should be realistic. You should say, well, tomorrow I'm going to do about 15 minutes of walk, light jog, and see how I'm doing. Increase that to every 5 minutes. So conditioning is very important. As your muscles need to be conditioned, so does your heart, lungs, and other vital organs for the rigors of what comes beyond. Even if you're planning, that's great. More important is sustenance, endurance in exercise, because it's very easy to develop a skill set and then let go of it.
Yeah. Another question that I'm sure our viewers will be hooked on to: alcohol. WHO has said that no level of alcohol is safe.
Yes.
But there are so many people who will tell you, अरे वो तो रोज रात को एक पेग स्कॉच का लगा के सोते थे, died at 90 plus. How would you like to address it?
Yeah, well, the thing with alcohol is it's a misconception that it only affects your liver. That's the first thing. So it affects multiple organ systems. In the cardiovascular system, the most common association is with hypertension and atrial fibrillation. So which is an irregular heart rhythm which can cause problems later on in life. Hypertension gives rise to thick muscle of the heart, increases the workload on the heart, stress on the heart. So these are the things. Though there's no direct linkage with heart blockages and heart attacks, as far as I know, there is a strong linkage that it increases the load on your heart. So it's a common misconception that only your liver is affected. It affects multiple organ systems. And yes, no amount of alcohol is a safe level that is recommended. So far as recommendations go, it's very difficult to categorically. So we do get patients who come to us and say, well, how much of alcohol is safe? I tell them there's no such recommendation.
And please tell me if you ever got a patient who said, I just have beer, a pint of beer, it's not really
lots
alcohol.
of them. Lots of them. Yes. But I think you convince them to a point, and then a diplomatic silence is what it takes to then get the point across. So yes, we cannot recommend alcohol in any particular dose. Yes, occasional social drinking is permissible, maybe about once in 2 weeks or so. A glass of beer won't, pint of beer won't harm you. But the problem is moderation is the key, and that doesn't often tend to happen because we have a confirmation bias in our minds which relegates all the negative things that we do. It's easy to just come and say, well, I do this, and most often the people who tell you that are the ones who are actually at the highest risk of getting disease.
And what about these heart healthy supplements, omega 3s and flaxseed oils, and even these seeds, for example?
Yes, so there is a role, as I said, in moderation. Omega 3 fatty acids have some beneficial effects. There's been no conclusive data to suggest that they increase HDL necessarily so exercise is the only known sustained form. Again, coming back to the alcohol question, there was a time when alcohol was pitched as the cure to HDL cholesterol.
Yeah.
Doctor साहब मेरा HDL low है, what do? I take in 2 pints every day. I said no. That bust was the myth was busted, but people would want to still live in that nostalgic era, thinking that that's the right answer. But coming back to the nutritional supplements, well, look. Monounsaturated fatty acids are important, but if you are not a performance athlete, a good balanced diet is what you should be aiming to go for. So by all means take supplements. If you are deficient, yes, please go ahead, test. If you are vitamin D deficient, which is the most common deficiency in our country, you can take them to a levels, but a direct linkage to various forms of heart disease, bone disease has not been established. So there's a difference between being a patient, having a biochemical test, and the implications are different if you are a performance athlete. So these are, we cannot mix and match and form a khichdi and say, well, this works for this, so this has to work for the other patient. So again, consult your doctor.
And I mean, we know obesity is a big risk factor. What is it that, you know, anyone who's overweight needs to know? And now we have these GLP-1 drugs and all of that. How do you see that, these new treatments coming in?
So yes, again, as I said, there is a role for these drugs in the right clinical setting. They started out as something to help morbid obesity. They do have long-term beneficial cardiovascular effects, because obviously if you lose a lot of weight, that is going to put, you know, your heart under much less strain. So it is unsurprising to see that there are various cardiovascular benefits of GLP-1 agonists. But there has been a lot of overuse, misuse, use as a shortcut method to, you know, shun away diet, exercise, you know, Ozempic and the like other realistic answers. Inclisiran will help you. That actually is something which needs to be clamped down upon, because there is no substitute to losing weight the right way, and that is the most sustained, because whatever is difficult to gain, you will take great care to make sure that you don't lose all of it. So and losing weight and then gaining back again, once you stop these drugs, the satiety center is activated, it comes back in a bad way, and then, you know, there is associated psychosocial implications of this. People then get into depressions and so on and so forth, which is again a negative spiral. So have a balanced diet, go back to exercise. These drugs do have a role, but in a select few, not in the as a whole blanket therapy for everyone.
Okay. And also something that I had to ask you earlier, but about these drugs, aspirin and a few other drugs that a lot of doctors and now patients also carry with them, that in case there's an incident, so they can just pop it. How does it work, and what are the medications really?
So there is a big role in heart attacks for drugs like aspirin and statin. The question is, have you defined the heart attack, or it's again not a blanket therapy? There was a large meta-analysis of about 55,000 patients in diabetics, and because diabetics is a high risk for blockages, which is why they studied diabetics. Should all diabetics above 50 should be having aspirin and statin rather? No, there was no clear benefit in that, saying that it prolonged life. But in the specific subset of patients with heart attacks who have stents, they do have a relative risk reduction of about 23 to 25% each in reducing the risk of major adverse cardiovascular events, which include death, sudden cardiac arrest, heart attacks, strokes, all of which is in the blanket term of atherosclerotic cardiovascular disease. They can have a relative risk reduction. So there is a big role of these medications, but who should be taking it, again, consult your doctor before embarking on this.
Again, one more thing, CPR. It's life-saving. But we have seen so many videos in the past couple of months where people are giving wrong, incorrect CPRs. So what exactly is the technique, and do you feel there needs to be more awareness around it?
So first thing is, there definitely needs to be more awareness surrounding this, because if you do CPR right, you will be able to save at least 1 in 10 patients yourself. I mean, and you will be at the point of response many a times, and especially with the situation, especially in metro cities with the transport and all, getting to appropriate medical care takes
Right,
time.
right.
Which is why if you find someone unconscious or by the roadside, first try to understand whether he has a pulse, whether he's breathing or not. Next, shout for help, and then start CPR, because and in the order of circulation, airway, breathing, not all of us are trained to be airway experts, but most of us can give good CPR to a patient. So the right thing is clenching your fists, and the palm of your hand should be at the lower third of the sternal border. So where the
Okay.
sternum ends is where you compress. You compress about 120 times in a minute. So you can count it in your
Mimicking
head.
the
0.5
heart.
seconds. Yeah. 1 second, 2 compressions is the ideal situation. But obviously there needs to be more awareness. There'll be workshops which go on for general health publics, corporates.
Right.
Ourselves, we have done a few of these, and there's very many doctors who create such awareness, and hats off to them, because that is something which the general public needs to be aware of, and learning CPR can save lives. So yes, that's one, public awareness. That's the most important thing. Then realizing what are the signs of someone having a cardiorespiratory arrest and falling unconscious, which may or may not be feasible in the setting. But if someone's pulse is not there, someone's heart is not beating, then CPR should be started on the spot, because every minute from then on leads to brain damage, because not enough blood is reaching the brain, and beyond a point, reviving a cardiorespiratory patient without brain coming back is a very bad sight. So and that can only happen because even in the heart muscle, even in the brain, time is the key. So every second that is ticking by is taking away from the heart muscle, and in cases of CPR, brain damage also occurring. So
Okay. So before we conclude, is it, if you had to rate workouts, safe workouts for heart, how would you rate them?
So any workout is safe provided your body is conditioned for it. So first thing is make a start.
Yeah.
So even when you're in your office sitting next to your computer, you can just take a couple of minutes out, do some squats or do something in your area. Take 15-20 minutes out at your home. If you're a homemaker, you can do that. You can go into yoga. Any exercise is good exercise provided it is sustained. If you are very much savvy and you are a performance athlete, of course the parameters are different, but all of us can do some form of exercise. And there has been no study. So the general consensus was 10,000 steps a day.
Correct.
150 minutes of moderate intensity exercise is what the Braunwald heart disease, our textbook, tells us. But you have to make a start somewhere. Not everyone can start with 150. I mean, someone who's grappling with weight issues may not be in a position to start. So do some form of exercise, do it graded. Do not jump to unrealistic expectations with exercise, because the more unrealistic expectations there are, the less likely that you are going to sustain this benefit of exercise. So swimming, cycling, jogging, walking, anything you do it regularly.
Okay. And off camera, you were telling me about procedures that you've just brought to India, and it's happening.
No. I mean, it's not that I've brought them to India. So they have been done previously. So I was talking about my training, my fellowships. So I've had an interventional cardiology fellowship in Cambridge at Royal Papworth Hospital. I was privileged to be an interventional fellow there for a couple of years, where I was doing training in mainly angioplasties. And then there's something called a structural heart intervention fellowship. So whereby I was training in percutaneous heart valve therapies. What that means is instead of open heart bypass surgeries, you can replace heart valves through catheter keyhole procedures without,
Okay.
so sometimes even in awake patients,
Mhm.
without the need for general anesthesia, you just go through the groin and
Uh-huh.
then you deploy a crimped valve. We have 4 heart valves in the body, and all of them can be replaced now with percutaneous methods. But the more important thing is that a heart valve team needs to be involved,
Mhm.
and we have managed to create one such team at our hospital,
Lovely.
whereby all patients who are referred to us for heart valve disease do get a consultation, and a multidisciplinary team meeting. So the multidisciplinary team meeting would involve interventional cardiologists, cardiac surgeons,
Mhm.
imaging cardiologists, cardiothoracic radiologists. If a patient is having concomitant disease like cancers, then the oncologist in question is called in or invited into the discussion, because they can give us a different perspective. The
Right.
anesthetist is on board. If there is anything surgical or percutaneous, the cardiac anesthetist can give. So every one of our team members has a role in getting patient-centric outcomes. So
Mhm.
so that is something that we need to be, focusing on. And the future is more towards precision medicine, minimally invasive techniques,
Mhm.
evidence-based techniques, because there's still role for surgery. So this is how, and the future of healthcare in India is very good. So
Mhm.
yeah, we've got some of the finest doctors in the world.
Lovely. On that note, thank you so much for
Thank you.
joining us today.
It's
And
my
it
pleasure.
was it was a lovely conversation. So many interesting
Yes.
takeaways. Thank you.
Thank you so much. Thank you for having me.